my experiences of my day-to-day practice. And whatever I am telling you is what I actually practice. It's not from the books. It takes a lot of work on the part of my assistant Dr. Aniruddha to make these presentations and to make it interesting so that all of us, including me and you, can understand and make it as lucid a presentation. Now this hand and wrist pain, many people will be thinking that, you see, it's such a small thing, but there are so many conditions in which it is very important to understand the anatomy, the physiology and hand as a structure, which was not there in many other parts of the body. Because this hand of a human being is the only organ which separates us from all the animals, including primates, monkeys. You see, monkey may be having a hand-like structure, but what differentiates us is this thumb. This thumb is absolutely prehensile. That means we can hold things like this, and the thumb has got such various range of movements that no other animal has probably been given this facility by Almighty. And even in our sagas and stories, we know that when Eklavya could become a master in archery, Dronacharya, the first thing that he asked him was a thumb, because he knows that this man will become absolutely non-competent after this. So, I have to discuss so many conditions in which for you all to appreciate the anatomy is very important. A little bit of it, whatever we will be talking, and we'll have to explain it because there are too many facts which is not possible for me to remember and tell you, so I have made it as a readable article. Now, the hand anatomy, when the skin is removed, you are seeing this membrane. This membrane on one hand is attached to a thin tendon of a muscle known as peroneus longus. It is the thinnest probably muscle in the body. And then it comes as a triangular fascia. This is known as palmar fascia. Palm means hand and palmar fascia, which is then attached to all these fingers. Now, this gives the maximum stability to the hand, especially when we want to carry loads or when we want to do some gripping work. Suppose if this palmar fascia is removed, then many of these muscles will not be able to work. And what are the diseases of the palmar fascia? As we proceed, I'll tell you. The other important thing is when we remove this palmar fascia, what we see are all these muscles and tendons. This one ligament is known as a transverse carpal ligament. This thing makes the whole hand as a tunnel from which all these muscles and the tendons are squeezed into it. And even the nerve which supplies the hand and the arteries are also squeezed to this fascia. This is known as the transverse carpal ligament. So you are able to, if you can appreciate this is a nerve. This white thing is a nerve, and this is the medial nerve because it lies in the middle. Here, what you are able to see, this is the ulnar nerve. This comes from behind, comes over here, passes through a tunnel, and then goes up in the hand and supplies these two fingers, the little finger and the ring finger, and only the inner side of the ring finger. Outer side is supplied by another nerve known as medial nerve. This is the ulnar nerve which supplies it. And here what you are able to see is the radial nerve. So the radial nerve again comes from the sides and it supplies this thumb and three fingers and half of this ring finger. This is the ring finger, the fourth one. So this is how the radial nerve supplies. So all these nerves get trapped at various places and give syndromes and symptoms which are very, very difficult to diagnose unless you are not clinically oriented as to what you are actually going to treat. So people come taking painkillers and all these things, but unless and until we don't make a clinical and a diagnosis by the help of various tests that we have got, lovely tests, we will not be able to do it. This is the behind side of the hand. Here what I have to appreciate first is again the same way this ligament extends over here, and you must have seen on that side as well as this side that each of this tendon has got a sleeve, a blue colored sleeve known as synovial sheaths. These are like how a wire goes to insulations. So the wire does not get short. Similarly, these tendons are in this sheets there is a fluid known as synovial fluid, and these tendons are able to smoothly move because of these sheets inside this fluid. The synovial fluid lubricates the movements of these tendons, and that is why these tendons have been able to put in at different places where they were the most efficient. Otherwise, suppose if this does not take place, there are so many times when these sheets become tight or the fluid inside dries off and the tendons are not able to move, and then we have to most of the time cut off this synovial sheet or first try with little injections over here. So I would like you all to appreciate. And last, when all these covers are removed, muscles and everything, we see the bones. Between them are these muscles, small muscles, interossei, which moves the fingers, and these are 6 to 8 carpal bones. In medical colleges, because the names are very difficult, we used to remember it by a mnemonic, that she looks too pretty, try to catch her. So the first one, she, is scaphoid. Then this is the lunate. Lunate is like a half moon. Then this is triquetrum over here. And on top of that you can see a small little bone which is actually going through a tendon. It grows in one of the muscle tendons, these muscles. So it is known as a pisiform bone. Same way the patella is a pisiform bone. Then try to catch her. So we have got a triangular bone known as triquetrum. Then there is a trapezoid, and this is the largest bone known as capitulum, and this bone is known as hamate. So this hamate has got a hook-like structure. Now why I am telling all this thing, of course it's very boring, I don't want to make doctors out of you, but this nerve, one of the nerve passes from here inside the hook of this hamate, and sometimes because of certain reasons it gets trapped. So that is why it is very good to appreciate the anatomy of the hand and how it works so well. We take it for granted, but there are so many things that can happen at any of these places. We'll see in the course of the lecture. Now, this is the first thing, this carpometacarpal joint of thumb. You see, this is because I told you that the thumb is the most useful structure, it is the most used structure. So many people who are, in works which they have to forcibly do something repetitively, like carrying bags, or in plumbers and all these people, they have to do heavy work. This joint gets inflamed. This is the first joint, and it is a very painful condition, and it remains for many days onwards. So we try to conservatively treat it by giving this gadget known as a spica. Spica is something which can hold the thumb in one single place. So because of this rest, that arthritis goes away. I mean, there are different types. These are available abroad, but this is the Indian one. This works very well. Sometimes if it does not work, then we have to give a local injection of inidase and a little steroid, and we give these exercises to the patients to extend the thumb. The whole idea why this thumb gets inflamed is because we are trying to hold things. The thumb is supposed to stay away from hand anatomically like this. But when we forcibly try to do this repeatedly, then this problem occurs. So this is known as the carpometacarpal joint. This is the metacarpal. All these are metacarpals, and these are the carpals. Yes, carpals and metacarpals. So we get this carpometacarpal arthritis. Now, similarly, any place, we can get this degeneration of the joints. The most common reasons that we see in day-to-day practice is osteoarthritis, as we see in the knee, and rheumatoid arthritis. Rheumatoid arthritis most commonly affects these small joints of the fingers. There can be many causes because of overuse, because of trauma, because of malnutrition. So we try to do different treatment, like for example, suppose if so many joints are involved, we give this type of a splint. Or most commonly we see arthritis of the middle finger carpometacarpal joint over here. So then we splint it with this index finger. So people get rest. If nothing works, then we give injection. If that also does not work, then we ask an orthopedic surgeon to put a wire across all the bones, which is known as the K wire, so it gives rest to the joint. In in this metacarpals over here, you can see that in these joints, every joint has got a cartilage, but these joint does not have cartilage over here. So the surgeon, we ask the surgeon, and they put what is known as a button, a silicone joint over here, and that it's like doing a total knee replacement. How we do? So they do a knee replacement over here. Now, this is one condition which I am sure most of you must have maybe either suffered or seen in people in your close relations or in your house. This is something known as a trigger thumb. Similarly, we see trigger fingers, in which what happens that one of these fingers, usually this ring one and the middle finger, once they close it, and they are not able to open it, and when they try to open it, it opens with a snap, cut like this. Sometimes it becomes so severe that they have to actually hold it with the other hand and then straighten it. So many old ladies I have treated, most of the times are old ladies who get this problem. So we call it either a trigger thumb when it happens in the thumb, or a trigger finger. Now what is the mechanism? Because of repeated use, or people who are not taking proper nutrition, malnutrition, and certain vitamin D deficiencies. You can see this tendon over here. This tendon develops a nodule. Now again this tendon is held by one of that ligament which I told you, because it has to move properly, otherwise it will go here and there jumble. So God has made this ligament over here, and this nodule has to go through the ligament and out. Then only you straighten the finger. But over here the tendon develops a nodule, and this ligament becomes like a pulley. So now this tendon is not able to pass from here. So it becomes tighter. Now this tendon has developed a nodule which can dissolve with a steroid injection. Most of the time it dissolves. Next. So we either give this injection, as you can see, it has to be given this way, from the finger towards the palm. If this does, then we wait for 1 month. If the patient does not respond, then we send him to a surgeon and he cuts off this ligament, this pulley, or this synovium, as you see. And then it is able to move freely. So this is that trigger finger syndrome. So many old ladies, they get it because of overworking. Now, as I was telling you, this metacarpophalangeal joint. You see, the two commonest evils are, one is an osteoarthritis, one is rheumatoid arthritis. That affects these joints first. But then the pain has to be diagnosed. There are so many conditions. You can find small fractures, just chipped off like this. Somebody has fallen, or in volleyball players, or basketball players, when they try to receive the ball, or even a cricket ball when it is hit by a fielder, it can chip off this bone over here and it gives pain. Then there are ligaments which hold these bone in places, in one sleeve, so that they are able to move. So we call them collateral ligaments. Sometimes this collateral ligament tears, or because of overwork or use. But still, as I told you, that the most common conditions are osteoarthritis, like the knee, and rheumatoid arthritis, which I will discuss in detail later on. Now, same way is this interphalangeal joint pains. Apart from all these causes I told you. Now see, this guy has got this volleyball injury and he has ruptured a tendon over here. A small ligament which joins the carpometacarpal joint. Here again, because of so many reasons, he has started developing osteoarthritis. Then you can see small fractures. These fractures are easily missed on an X-ray. Many a time you have to ask for a CT scan. Sometimes when people do have this osteoarthritis and all these things which are in a stable phase, then we ask them to different physiotherapy is given. One of them is exercising with these medical balls. And sometimes when in osteoarthritis we know that it is highly inflamed and we split the finger. I'll show you an exercise chart later on in one of the slides. Now this is a very common condition in young housewives. See, we call it, the other medical name is a Boehmer's disease, or this is dequerulin tenosynovitis or a tenovaginitis. What happens that in the thumb, you can see the first thing. See, these two muscles which you are able to see, these two muscles are main muscles in the thumb. I mean, they have got a name. One is extensor pollicis brevis and abductor pollicis longus. So these two tendons which are able to see, their main function is to keep the thumb, as I told you, away from the hand. But we have to do work every day and we push them to bring the thumb as close as possible. Then only you can pick up things or open jars or turn a key or do whatever. So this synovium, as you are able to see, this synovium is also there in these tendons. And the fluid inside, it gets dried off and the synovium gets thickened. So when it gets thickened, there is lot of pain over here in this part of the joint. And this is the test. This test is known as Fenkenstein's test. You ask the patient to hold the thumb and then you forcibly bend it up the whole hand and they get severe pain over here. Now, hynidase is a drug which liquefies this thickening, and you have to mix it with little corticosteroid and give it in a particular way. It is given by a very thin needle and it has to go between the tendon and the synovial sheath, and the fluid again comes back and all the swelling goes away. Sometimes we ask them to put a splint like this and give them exercises. These are exercises for these dequarians, tenosynovitis. It is known as a vaginitis also, because like a vagina, it has got a small passage like a childbirth, and eventually when nothing works, we have to ask the surgeon to remove this synovial sheath. When he removes it, the tendon becomes free. Now, carpal tunnel syndrome, this is the commonest disease that we see in our practice. Commonest. As I told you, that you see, this is that carpal tunnel ligament or a transverse ligament of the wrist. Now, from this, so many tendons are pushing inside from this passage, from this tunnel. Why God has done this? So that you get a stability of your hand. Suppose somebody cuts it, then you do not know whether your finger will, while trying to hold something, will not become like this or like this. You properly hold whenever you want to hold. But this median nerve, I was talking this median nerve, it supplies these three fingers, index finger, middle finger and half of the ring finger on this side. If this gets trapped over here. Now this disease is commonly seen in middle-aged women. They commonly have a habit of putting their hand under the pillow and sleeping. So many women sleep like this. And in the middle of the night, they wake up because their hands have become numb. They try to jerk it off. Sometimes, and it is also very painful. So what they do, they go and put it in hot water for some time. But if it does not work, then the best treatment for them is we give them some splint. We ask them to put a ruler like this, the tire ruler, so that the hand remains straight, because that prevents the flexing of the wrist, so that nerve which is pinched inside this ligament is not pinched, and they become alright. The ruler also keeps the husband away and the children disciplined. So many functions. So sometimes, that really works wonderful. The other thing, we see it in elderly women. Why? Because in India, 80% of women have got less thyroid, hypothyroidism. So many women you will be seeing at a middle age, they are taking thyroid tablets. So this hypothyroidism is the commonest cause. Second is obesity. Even those men who do some industrial work, like they are electronics engineers, they turn these screws this way like this. So they also get this carpal tunnel syndrome over here. So we have to inject this hynidase and steroid from this side up towards the palm. If it does not work, then again the surgeon has to cut this ligament. But then you lose the stability of the hand for a certain extent. No. This stability, because you are cutting it off. No?
It will be
permanent. That stability loss is gone. You have to lose something. Because this pain and numbness is too much. And when do we send it? When do we send it? And you are right. You are able to see this. See, the muscles on the sides of the thumb have become wasted. They are atrophied. They have shrunk. So this is a situation when if you wait long, these muscles will become functionless. There are 3 muscles over here and 3 muscles over here. these three muscles will become functionless. So before that happens, a physician should be able to know that this guy requires surgery. Now, as I told you that there are three nerves which passes through this transverse ligament. One was the median nerve. If it gets trapped, was the carpal tunnel syndrome. Second is this is very uncommon, ulnar tunnel syndrome. This is when the ulnar nerve gets trapped in that canal. I had showed you that canal, that hook of Hammett bone and the pisiform bone in those bones. See, this is the Hammett bone, the pisiform and the Hammett. So this ulnar tunnel this ulnar nerve comes from here, then it comes here, then it goes over here, then between this from the hook of Hammett, then it travels up over here. So many people, like these people who repair tire puncturers, then people who have got a habit of standing like this. There are so many people who puts one hand like this and brushes their teeth every day in the morning. I always ask them when such a case comes. So they get this, tingling and numbness of these 1.5 last finger, the ring finger and a half of ring finger and the little finger. And it is very distressing. They tell you that when I try to empty some kachra from a table, I don't feel anything in my hands. I don't know what I am feeling. And there is one thing to remember, that this ulnar nerve, it travels from the neck on the inner side of the elbow and inner side of the hand into the palm. So we have to make sure that it is only ulnar tunnel syndrome and not anything else, because the commonest cause in India of getting this nerve trapped is in this elbow. The nerve goes behind the elbow on the inner side, and leprosy is the commonest cause. So many a leprosy are just diagnosed when a person comes with tingling of this side of the hand, this much. We first would like to rule out leprosy, and then this ulnar tunnel syndrome comes. So the best test to diagnose is an EMG nerve conduction study. In that nerve conduction study, they put small needles everywhere. They pass the current and see where the current is not coming, like these modern day line testers. These nerves are like wires. So how we test that where the wire is broken? So they find out where the nerve is trapped, whether in the neck or in the elbow or in the wrist. Now this ulnar tunnel syndrome, the only way is to give the injection inside this canal. See, here it is. This is a Calcuttawala. So we have to give an injection into this ulnar tunnel over here. Because we have to give it from the back and then put the needle in front and enter between these small bones and put the drug. Otherwise, it's a very distressing symptom. There is one condition which many people get, not everybody. Mainly, and they are showing these prisoners who have to wear handcuffs and all these things. But in day-to-day life, people who have got a habit of wearing wristbands, or who swoop on bikes, or something tight which they wear over here, bangles and all these things. So that median nerve, there is one more. I told you there are three nerves in the hand. One is that ulnar nerve, one is radial nerve, one is the median nerve. So you saw this entrapment of radial nerve, median nerve. But this radial nerve, again the first slide. This radial nerve has got, before it enters the wrist, it branches into two parts. One which goes from underneath this canal, that controls all the muscles. And there is one nerve over here, as you see, it goes over this ligament, above this ligament. One branch goes below the ligament. So this part is the sensory part. This gives you all the sensation of hot, touch and everything on this side of the palm. So this nerve, when it is trapped by this handcuff or wristband or something, now continuously there is paresthesia, tingling numbness. We call it tingling numbness, junjuni, in this part of the hand, the thumb and the fingers and all this. These are very distressing. This is one condition where we don't need any injection. Once you remove the cause, within 6 months, that wire which is trapped, this nerve, it again starts conducting the currents. So this symptom goes away. This is a common thing which we see in young boys. Now in the days of computer and people, young boys sit for hours and hours.
Longer time. Longer time.
Longer time. And what happens that I showed you those sleeves of the tendon, those blue color things. So because of the continuous friction of the tendon on these bones, or because of certain positions, there is water which gets filled inside the sleeve, and this sleeve pops out from between the bones, and they form a ganglion. This is the ganglion. This water is thin first, then as the days passes and he does not get himself treated, it becomes thick viscous fluid, then it becomes hard. In former days, this was known as a book bump or a Bible bump, because the treatment was that we had to put the hand on a table and with a large book, a thick book, we had to hit it hard, and all the fluid would dissipate around. But it would eventually come after 6 months or 1 year. Now since we understand what is the disease, so what we do is we put a needle, aspirate the fluid and inject little hydrolase or steroid inside and give a tight pressure dressing. And then this does not recur again. So this is the treatment. But then you have to see sometimes that fluid, it's like jelly when it comes out. It is so difficult, you have to use all my force to aspirate and to suck it out.
Earlier this chemotypes also used to get it. Typists earlier used to get it.
Yes, earlier typists used to get it. Now with this computer it has changed. You are right. Because of friction of tendons. Now I showed the first thing was that palmar fascia. So this is the disease of this palmar fascia. Incidentally, this is one disease which does not have an obvious cause. One obvious cause that I have seen in people is those who are in sports. So when they damage, they try to stop a ball or something, and in that, I told you that triangular fascia was that palmar fascia. So they destroy it. But most of the time, this dependence contracture is associated with alcoholism. People who get liver disease because of alcoholism, diabetes, thyroid, certain drugs, and we see mostly in foreigners. What happens is these two fingers, they bend down and they are not able to straighten it, how much ever force you apply. And this goes into contraction. This is the
main cause is alcohol.
Main cause is alcohol. I have seen mostly people who consume alcohol. Now this is a painless disease. It does not cause any pain. So people ignore it, they go on for years and years. So one of the treatment is, we either inject steroid, but at multiple levels under anesthesia, we puncture it with a needle and we try to loosen up that fascia. But if it does not work, then the surgeon has to cut off the fascia at many places, known as fasciectomy. Sometimes X-ray radiations, we call it radiotherapy, that also works, and that palmar fascia becomes loose and the hand straighten. But many a time, we have to send to a plastic surgeon who cuts off that fascia extensively and then resuture this. You can see the thickening. These people also have been seen that they have got callosities in their palm, hardness, thickening of the skin in the palms and the sole. For what reason? We don't know. They have got a tendency to get thickness in everywhere, all these tendons and skin and everything. Exactly. That is the place. So they get this dependence contraction. A French person, Casemo Guillaume Dupuytren, he was the first to describe this. That's why it's on his name. This is a very interesting disease. I am calling it the disease because it is not because of anything else. We really don't know why this happens. In this, the hand suddenly gets a swelling over here. It is red, inflamed and brown like wood. We call it a woody swelling because the hand becomes quite thick. It is very, very painful and there is no cause. When we take an X-ray or anything, all the bones and everything is normal. It is usually seen in very, very poor class elderly females, who have got a lot of frustration in their lives, husband not looking at them. So when we found out that cause, it's from the brain, so they have shown. So these people have got a tendency, in the frustration in their free time, they go on banging their hand with hard surfaces. They hit with the table or the wall or something, and in that process, they go on inflicting injury. So many a times we have to give antidepressant drugs, or we tie soft bandages over here, and sometimes multiple small steroid injections resolve this edema or a brownie edema, hardening, and it goes away. But it's very difficult to guarantee that it will not come again because the cause is not known. The other name for that disease is reflex sympathetic dystrophy, RSD. Is everywhere people will tell you orthopedic surgeon is known as RSD, secretary syndrome. This is one disease which I have included because most of the time the diagnosis is not very easy and people miss it unless they are not very careful. Because of some trauma or somebody trying to getting up from the ground with their hands, they fracture this bone, this unit over here. And you see there is...
This bone is little bit out here.
No, it is not out. In fact, it is in. But you see, because of the pressure, because the bone is in, it has got a very critical blood supply. You can see the blood supply is from so many places, but this particular bone does not have a very good blood supply. And suppose if it gets fractured, so it does not heal, and on the contrary, it goes into what we call as a avascular necrosis. The bone gets rotted, see? And it does not heal, and the pain is terrific. So what we do is first we try to put bone grafts. Suppose if it does not work and still the pain is there, we remove all the 3 bones and we join this bone by a plate. Even that sometimes does not work. We have to cut these bones also and fuse the whole wrist. Now we cannot do any movement of the wrist stiff. But he has to lose the movement to get relief from the pain. No painkillers, nothing will work on this. Unless, it is very easy to miss out except for an MRI. Somebody thinks of an MRI and this disease and you got Kienbock's disease. Now I told you about this osteoarthritis. This is more common than what we think that we see. People who have to do fine works with their hands, like surgeons, like people who are doing embroidery, handicrafts, Calcuttawalas, they get it. So this is just like the mechanism is just like the osteoarthritis of the knee. But only difference is that this joint, this small joint, they do not have the cartilage which the knee has. The cartilage is only over here. So see, the pathophysiology is same like arthritis. So we have to only ask them to rest. So we give them splints and all these things. If it does not work, we give multiple injections in the joint. In the last resort now, Americans have developed these silicone implants over here. So sometimes you have to put silicone implants at multiple places. This is just like a knee replacement. So how you replace the knee? You have to replace the joint over here. And they get all these nodules, knotty, swellings over here. They are known as Herbert's nodes. It is a diagnostic sign that this is osteoarthritis and not other arthritis. Rheumatoid arthritis and all these things have got different manifestations. But this is diagnostic of osteoarthritis, and it usually reflects in these first 2 joints, not this. Carpal joint, it does not affect it so much as this, because they are doing fine work. They have to hold needles and all these things for long hours. This is, of course, the king of all disease, rheumatoid arthritis, and hand and wrist pain is most important in this because it first affects the small joints of the hands and wrist. That's why rheumatoid arthritis is very important. People have got a tendency to call everything as rheumatism. It's not so. Rheumatoid arthritis has got a very classical etiologenesis. That is, it is an autoimmune disease. What happens is the synovium. Synovium is the underlining of the capsule of this joint. So that the body does not understand that this is my synovium. It starts creating antibodies and fighting with it. So that synovium starts secreting fluid, synovial fluid, which has got a lot of toxins. These toxins destroy this cartilage, bones and other things around the joint, and it gets all deformed. So we get all these deformities like bottom neck deformity. This is known as a swan neck. It's like the neck of a swan. and this is a bottoner. Bottoner means like a button. So those people, who are button stitching, they get all these kind of fingers. And because of this destruction, all the fingers, go towards this inner side. So we call it an ulnar drift. These are in advanced stages of the disease. Now in England, all
They
this.
lose their original place. No?
Yeah, they lose their original face. So there are surgeons who are specially trained only to treat rheumatoid arthritis and these complications. They have to remove the tendon from one finger and again they have to put it in another finger, and that's how they gradually, so many stages of surgery, they again straighten the fingers. But it costs a lot of money, so in India nobody takes interest. So many people are afflicted.
This is only the synovial joint.
Only the synovium, that is the covering of the joint, gets this thing. What is the difference between osteoarthritis and rheumatoid arthritis? Clinical. That osteoarthritis is a disease in which pains with movements. The more movements you do, the more work you do, the more it pains. Rheumatoid arthritis pains with rest. So we call it morning stiffness. In the morning, people feel that the fingers are stiff and they are not moving. It takes about 1.5 hours for them to come to their work
It
schedule.
looks like a numbness.
It's not numbness, it's stiffness. They feel stiff. They are not able to bend the fingers. So that is rheumatoid arthritis. But with work, when it pains, that is osteoarthritis. But rheumatoid arthritis is actually autoimmune diseases. It is there. So we give all drugs which fights this autoimmune. That means it stops the body from fighting with itself. The first drug is cortisone. Then we give along with it painkillers. But nowadays there are lovely drugs which we call immunomodifying drugs. Formerly they were named as DMARD, disease modifying anti-rheumatic drugs. So methotrexate, azathioprine, sulfasalazine, penicillamine, gold, even gold is given for this disease. And now we have got amazing drugs like ethanosertib, infliximab. That hits at all the antibodies which the body is producing to kill the synovium or to inflame the synovium. So those drugs shut the body down, and then the person has got a good chance for the pain relief, but then he has to do either exercises or surgery to straighten whatever damage has been caused over so many years. This rheumatoid arthritis affects any joint. Now we are seeing so many cases where there is only one joint, let's say one knee in a young girl. She comes with a knee pain. They go to so many people. Only one joint, that is a knee joint, has got rheumatoid arthritis.
Other joints are okay.
All other joints are okay.
Because of bending the one leg.
No, I told you it is an autoimmune. The body forgets this is my own organ and it fights with it.
It doesn't affect other organs, other joints.
Other joints, it means the presentation. First presentation is with one single large joint. Usually rheumatoid arthritis is a disease of small joints. But it also, affects other organs, like they get uveitis, inflammation of the eye, inflammation of the lungs, the liver. They get severe anemia. These people are always little febrile. They have got fever.
It's a systemic disease.
It's a systemic disease because synovium is everywhere. So it can affect any organ. So these are the things we have to consider before diagnosing. Osteoarthritis will not affect all the other organs also. But this one disease is a big challenge for everybody. Means to what stage the patient has gone, and so we have to choose the drug. Raynaud's disease, not very common in our country, but yes, in the upper elite class, this is a very common disease. For some reasons, these people, they secrete certain chemicals and they are allergic to cold. The moment they are exposed to cold, they pick up ice or they immerse they wash the utensils in tap water. Suddenly their blood vessels which are supplying blood to the fingers, they shrink, they collapse, they go into spasm and they get a pale fingers like this. So they feel that their hands so much cold and numb that they try to immerse their hand in warm water or they put it in their armpits or wherever they find warm. After they make it warm, then the color changes from this to blue because still the blood is not there and there is more carbon dioxide. So we call this like a cyanoacrosis or a cyanosis. And then after the blood comes, suddenly it becomes red like this. Now when you see these patients, their fingers, in a normal state, when they don't get this episodes, so in the normal state, their fingers looks like this. They have got all these cuts everywhere, and they have got those black dirt which is, fixed in these cuts. So we know that this person is a Raynaud's person. So we try to give them a lot of vitamins and all these things which keeps their blood vessels dilated. This is Raynaud's disease. And in cold we always ask them to put socks and these mittens so that they don't get this part. You can see these fingers because of Raynaud's have gone into gangrene. This is dry gangrene. These all fingers will fall off. They are dead. So this is that stage that they reach. In snow, this is very common. I mean, these are on most of the
diabetes patient get more affected.
No, that is a diabetic gangrene. In diabetes, what happens is the artery becomes thick. Here the artery goes into spasms. Over a period of time it becomes thick, the blood supply is not there and they go into wet gangrene. This is dry gangrene. So these are all medical conditions that I have described. Then common, as I told you in one of my slides, the common cause of hand and wrist pain are fractures which have not been diagnosed. So many places we get different kinds of fractures. Now there is something in the boxer's fractures. Somebody, your boy comes from the school and he goes on saying that I have got pain over here. He has tried to fight with somebody and he has fractured this little finger. He will not tell you that a fight. But you have to somehow, from the X-ray or MRI we pick it up. Then there is a Bennett's fracture over here of the thumb. Same way, this is a very common fracture which you see in old people. When they fall down, they get this pollicis fracture. You will see this like this. On an outstretched hand, somebody falls. Pollicis fracture. So they get this and they have to put a plaster for about 2 to 3 months because the healing is very bad. These are some of the treatments these surgeons do for different kinds of fractures that they see. And many a time it's not picked up all these hairline fractures on X-rays. So we need either a CT scan or MRI. Now this is a fracture of the hook of hammock. We see so many people, who are young boys who have fallen down from their bicycles. That's the commonest cause that I see of this fracture of the hook of the hammock. In those cases, we have to give a plaster so that their hands are like holding a wine cup for about 2 to 3 months, and then these fractures heal. Sometimes you have to remove the hook of hammock because from here, that ulnar nerve, I told you that ulnar tunnel syndrome, that ulnar nerve goes from here, this place, into the palm. These fractures have to be always kept in mind and diagnosed. Otherwise you miss it, and what happens, the worst thing is that it causes early arthritis of the wrist if those fractures are not diagnosed and treated. I think that was all for today.